5 facts about pediatric scoliosis. Unfortunately, scoliosis affects all ages, from babies to elderly and every age in between. The most prevalent form of scoliosis is adolescent idiopathic scoliosis, and this is diagnosed between 10 and 18 years of age. Now, technically, adolescents are still in the pediatric phase, but the way scoliosis affects adolescents is very different than how it affects younger children. So when we look at pediatric scoliosis for this, we're talking about kids that haven't gone through their initial pediatric pubescent growth spurt, and this typically happens somewhere between 10 or 14 years of age, depending if it's a female or male. Now, when we look at this, we know there's significant differences. Fact number 1, when we look at pediatric scoliosis or juvenile scoliosis, meaning cases that are diagnosed between 3 and 10 years of age, that early diagnosis and early intervention increases treatment efficiency, and it definitely increases the outcome. This is true for all patients, but especially true for patients under the age of 10. Like, we know that when conditions, when we see scoliosis early and we treat it early, we can have the greater impact on how the curve will develop and progress in adolescent stage. In these cases, most common sign is going to be uneven shoulders, uneven hips, uneven posture problems. We normally don't have any kind of functional concerns, but as a progressive condition, we know that, and normally progressing during growth spurts, that this curve is progressing, and as it's gaining some speed before this adolescent growth spurt, we know that if we treat the curve now and they go into adolescent with a smaller curve, the less likely it is to progress in the adolescent stage. We also know that they're probably not going to feel any pain at this stage, so just because the child isn't experiencing pain doesn't mean it shouldn't be a reason that you shouldn't treat it. So treating it younger definitely will produce a better result. Number 2 is observation and examinations only are normally the standard treatment options in traditional treatment of scoliosis. Traditional scoliosis treatment for juvenile scoliosis typically recommends just watching and waiting, and this is normally true in the mild phase, and very often it's true in the moderate phase, because normally they don't like to brace these kids because they say they're going to be in the brace too long, and therefore they don't keep them out of a brace, and normally they don't even recommend surgery sometimes in these cases, even if they become severe, because they're too young to have surgery. So normally they're just watching, and they're seeing this curve worsen and worsen. Now, they may recommend surgery as the curve becomes relatively significant. They may recommend a brace if they feel like they need to, but most cases they're just watching. Where in these traditional treatment options, sometimes bracing is used, but it's, again, the brace is normally used to only slow down the progressive state. The brace is not used to three-dimensionally correct the scoliosis, and it's normally reactive, meaning they're seeing the curve worsen and then they give bracing. They're not trying to treat the curve to reduce the curve before it worsens. Fact 3, children with scoliosis need some type of exercise or therapy. Juvenile patients who avoid exercise because they have scoliosis lose strength, lose mobility, and they can actually make their scoliosis harder to treat. The more fit the child is, the more aware they are of their body, the more they're aware of their muscles and tissues, the greater chance we have of getting a better reduction with their scoliosis, because in our approach, especially in a conservative approach that's more functional, the better their body functions, the better we can use their body to help improve their scoliosis. We also know exercise can increase bone density, we can strengthen the body, make it more responsive to treatment. So we like exercise for juvenile patients. We not only do we like our scoliosis exercises, we also like any type of sport or physical activity they can perform, and we normally like for them to do whatever they like to do, because if they're involved in a treatment process, any sport they do, it may have some compressive or negative effect to scoliosis. We're undoing that. And again, most of these kids, need to have some type of life outside of just scoliosis treatment. So we recommend them being active in any type of sport they like to be. Number 4, surgery is not an option for many juvenile cases. Scoliosis surgery is typically not recommended before adolescent growth spurts. And the reason why is because if they do surgery too early, it's very complicated, because as the spine is growing, they're fusing the spine and they're stunting growth in those areas, which could require subsequent surgeries and multiple surgeries as patients go through adolescent growth spurts. So they try to not do surgery. Now, unfortunately, They will do surgery in juvenile cases if the curve becomes significant enough and if they see progression. The problem is a lot of times they're doing nothing to try to stop the progression. They're just watching and waiting and see what happens. And then if their curve starts worsening, then they start reacting. So we like more of a functional approach that's going to reduce curves in these juvenile stages. Our rule of thumb is in a juvenile case, you never just want to watch and hope that it's going to stay. You want to reduce the curve and make it smaller. Now, the argument is going to be this, is that the orthopedic doctors or surgeons are going to say, well, we don't know how much worse this curve is going to become. And I don't disagree. We cannot predict how much a curve will progress during growth and development. But let's say the person has a 20-degree curve, and let's say it wasn't going to get any worse. It was only going to be 20 degrees. Well, taking a 20-degree curve and making it 10, there's no harm in that. The person has a smaller curve, they're going to be better off. But letting a curve go from 20 to 40 or 20 to 50, well, there's significant harm there because now the person has to consider surgery. So that's why making a small curve smaller doesn't produce any negative effects. Letting a small curve become bigger does. Number 5, chiropractic-centered treatment can effectively address juvenile scoliosis. We know the younger the patient, the better results. We know conservative treatment definitely can help children avoid the need for surgery and later in life. And we know this chiropractic-centered treatment approach can have a very significant effect on small curves. Younger patients, smaller curves can have a much greater impact, meaning, like I said, we have no idea how big a curve is going to become. So if we're looking at a patient, say at 7 years old with a 20-degree curves, untreated, we don't know if this curve is going to become 20, it's going to become 40, it's going to become 60, it's going to become 80, it's going to become 100. The biggest curve I've ever seen in a child has been 155 degrees. You got to understand that curve at one point was probably less than 20 degrees. So impacting the curve at that stage and making it smaller can have a tremendous effect on stopping the progression. So statistically, this is what we feel. When a person enters puberty and enters that growth phase, a curve less than 25 degrees, 1 of every 3 untreated becomes severe over surgical standards. Once they break 25 degrees, 2 of every 3 become surgical during their pubescent growth spurt. So keeping curves below 25 degrees to me makes the most sense because we know that's when percentages change and they're more likely to become severe during growth. So why we treat curves when they're smaller to keep them smaller. But truth is, most traditional treatment options don't initiate treatment until curves break 25 degrees. So it's like the opposite. Once the statistics increase, then they treat it. Why don't we treat it to keep the statistics from ever becoming that high? So when we look at pediatric scoliosis, we know it definitely includes adolescents. But when I'm talking about pediatric scoliosis, I'm talking about juvenile scoliosis. I'm talking about cases that have not hit their first growth spurt. We know when they hit their first growth spurt and they go through this significant growth and development, that's when curves progress the most rapid. So reducing the curve before that time can produce a much greater outcome because we're reducing the risk of progression and we're dealing with a smaller curve. In addition, the straighter their spine is, and the more likely they are to get a better response during this adolescent stage. So I really want parents and caregivers to understand that we know scoliosis is a progressive condition. We know growth is by far the number one risk factor. We know the early signs of scoliosis is not pain, it's not malfunction, it is only posture, and that should be a sign enough to treat your scoliosis and to reduce the curve to make sure when you go into the adolescent stage, you're more successful to come out of the adolescent stage into the adult stage with the smallest possible curve, not just a curve and not considering surgery. Thanks for watching. I hope you found this information helpful. If you'd like to hear about other topics and information on scoliosis, type in the comments below and let us know. And finally, subscribe and hit the bell icon to be notified of when we publish content. Thanks.